Hello and welcome everyone to tonight's webinar, the fifth and final webinar in our sleep webinar series, brought to you by Capital Health Network and a multidisciplinary team of sleep physicians and sleep psychologists in the ACT. If you have joined tonight from your phone or tablet, you might wish to swap to a device with a larger screen now while we're going through the introductions, just to make the most of the visuals in tonight's presentations. So if you'd like to do so, you can log off and rejoin from another device. But before we get started, I would first like to acknowledge the traditional custodians of the land we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome any Aboriginal and Torres Strait Islander people who might be attending tonight's event. Their land was and has never been ceded. Tonight's webinar focuses on continuous positive airway pressure troubleshooting and obesity hypoventilation syndrome. My name's Michaela DeLeva. I'm a physiotherapist and quality improvement project officer at Capital Health Network. Also with me tonight is Dr. Deborah Inman, respiratory and sleep medicine physician, and Dr. Carol Huang, respiratory and sleep physician at Canberra Health Services. And of course, we have with us tonight Kanal Mahiti, the events lead here at Capital Health Network. Just a little bit of housekeeping before we get started with the presentations. You'll notice that all participants have been muted, so please address any questions that you might have for either presenter in the Q&A section. Please try not to put them in the chat box of your Zoom panel, and we will have a question and answer session once both Dr. Inman and Dr. Huang have finished presenting. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're more than welcome to share this amongst your networks. In regards to CPD, please fill in the post-event evaluation survey that CHN will email you out shortly after tonight's webinar. Then you'll receive your certificate of attendance after the event via email. Please feel free to self-report 1.5 hours of educational activities to your CPD home for attending tonight's webinar. Before we start with the presentations, I'd also like to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including a wide range of respiratory and sleep disorders. If you wish to access the website, the login is together and the password is for health. Health Pathways are a reliable source of up-to-date clinical and referral information that has been localised to the Canberra region. Your feedback is invaluable to keep these pathways updated and reflective of the local health environment, so you'll find a feedback tab at the bottom of every pathway, and we encourage you to use them. I'll now introduce our first speaker of the night. Our first speaker tonight is Dr. Deborah Inman. Deborah is a respiratory and sleep physician at Canberra Hospital and has been the clinical director of the Department of Bariatric Medicine since 2022. Her main research interest is in obesity, sleep, and post-bariatric care. And Deborah also has her SCOPE certification. Please join me in introducing Dr. Inman.
Thanks, Michaela. I'm just going to share my screen and hopefully you can see that.
Yep, you're all good to go.
Great, thank you. So thank you for having me back. And as you might have noticed, we've changed our name at the Obesity Management Service to the Department of Bariatric Medicine. And I also work at the Department of Respiratory and Sleep Medicine. But I'm just going to leap straight into the overview. Oh, hang on, if it will. Just let me stop and try again. Did this to me in the practice, but hopefully Hopefully that will work. Let's see. There you go. Okay, so just a quick introduction on obesity and sleep, and I'm going to use a case presentation throughout the course to try and illustrate some of the principles of the condition. And I think it's important to consider that for hypoventilation, although my talk is about obesity hypoventilation, some of these principles are useful outside the population who do have obesity and can be helpful in the back of your mind when you're thinking about patients who have similar symptoms. I'm going to focus more on the clinical side of things rather than pathophysiology because it is, I think, complex and difficult to understand and does differ in different patients. So if you have questions about pathophysiology, I can try and answer them at the end. So just as a brief introduction, with my obesity physician hat on, and the word obesity is in the title of this condition, I'm interested in sleep. It's fundamental to health and is both a significant contributor to obesity, but also as a consequence of obesity, sleep can be impacted. We know that disruption to sleep has adverse metabolic impact. So smaller studies looking at metabolic parameters in states of sleep restriction, circadian dysregulation and shift work, and then also larger population-based studies showing the risk of weight gain when people have these conditions imposed upon their life. And while I think we're pretty familiar with obstructive sleep apnea and have a good understanding of its adverse health associations, it does impact people very differently, and symptoms are manifested sort of through a high range. Some people can be very asymptomatic and just experience snoring, and others have quite significant impact on their day-to-day lives. Fundamentally, sleep apnea can induce sleep fragmentation, functional sleep restriction, the hypoxemia and sympathetic activation associated with arousals and hypoxemia sort of lead to many of its adverse effects. Sleep disorder breathing is common where there is obesity, and this is in our sort of local cohort at the formerly named Canberra Obesity Management Service. But on first presentation, the prevalence of obstructive sleep apnea is about 50%, so more than that of diabetes. And we have perhaps a slightly biased approach, but we have a strong interest in sleep disorder breathing, and we undergo active screening for all our patients and investigation, and the prevalence then after that is over 70%. Our cohort is typically female in their mid-40s and has a BMI in that class 3 range, reflecting our referral criteria. So I'm going to leap straight into the case. So this was Mr. L, who was 53, and he was referred to our service in 2020 for management of his class 3 obesity. At presentation, the weight was its highest it had been at 208 kilograms with a BMI of 70. He had a background history of a diagnosis of type 2 diabetes made in the last year. He'd had a previous pulmonary embolus in 2019. He'd had an admission for admission and had been treated for recurrent bilateral cellulitis, which I'm always a little bit inherently suspicious of and wonder about right heart function. He'd had depression, dyslipidemia. He was an ex-smoker with an unclear PAC history who quit more than 20 years ago, carried a diagnosis of COPD, osteoarthritis, and he'd been having intermittent PR bleeding with iron deficiency. He'd also had a diagnosis of obstructive sleep apnea and was using CPAP every night. What wasn't mentioned on the referral but rapidly became apparent was he did have a degree of intellectual disability. He'd left school after year 10 and worked at a supported employment institution that supported people with disabilities. He no longer worked due to his physical health, had a disability support pension and NDIS funded carers who helped him with his activities of daily living, such as cleaning and shopping. His goals were to try and improve his health and to get help with his cooking. And also in the lead up to his presentation, he'd had an admission to the local peripheral hospital with heart failure. His medications are as listed, so his anticoagulant for PE, metformin for diabetes, rosuvastatin ezetimibe for his dyslipidemia, some perindopril, venlafaxine, and Trelegy for his diagnosis of COPD, and was using salbutamol quite frequently for breathlessness. And he had tramadol intermittently for his osteoarthritis-related pain, joint pain. Some further history and examination, he was definitely breathless. He was quite breathless after the walk to the consulting room, and that was one of his major complaints. He reported he could walk as far as 10 metres using a stick, with both back pain and breathlessness limiting this. He feels he never really recovered after his PE diagnosis a couple of years ago. He was somnolent, so his Epworth sleep score was 19. He reported occasional headaches. and his affect was slightly dulled, and he appeared plethoric. He had used his CPAP nightly since diagnosis on a pharmacy-based sleep study in his 30s, but had no specific follow-up either with the pharmacy or a sleep technician or a sleep physician. He reported problems with mask leak and gasping arousals despite his CPAP. On examination, he had saturations that were mildly reduced at 93% on room air. He was mildly tachycardic and hypertensive. I thought he had a CO2 retention flap. He had reduced breath sound intensity and heart sound intensity consistent with his body habitus, but no additional sounds could be auscultated like crackles. And he had extensive pitting edema, both lower limbs, all the way to his lower abdominal apron, poor skin condition in his feet, and poor dentition. So obesity hypoventilation was first described in 1955 and later associated with the term Pickwickian syndrome. Its criteria stipulate that there is the presence of obesity, so a BMI of greater than 30, daytime hypocarbia defined by a CO2 on blood gas of more than 45, hypoxemia, and usually there is sleep disorder breathing. So a sleep apnea is comorbid in 90% of patients, but not always. It is a diagnosis of exclusion, so obstructive, restrictive lung disease, central causes of sleep apnea, neuromuscular or chest wall problems such as kyphoscoliosis, and sedating medications or opiates, for example, may also have a role. But of the causes of hypoventilation, obesity would be the most common. The ERS, European Respiratory Society, in 2017, their task force on complex sleep apnea proposed some staging of obesity hypoventilation. So the sleep state does offer us a bit of a window into how the breathing system functions. Hypoventilation or respiratory insufficiency first appears during sleep, particularly during rapid eye movement or REM sleep when there is additional muscle weakness induced by that REM paralysis, and it progresses along a spectrum to end-stage disease and failure of the respiratory and cardiovascular system. And this is true for other causes of hypoventilation, not just obesity. For example, motor neuron disease, muscle weakness, and hyperventilation first appears during REM sleep, for example, and sleep before it proceeds to daytime hyperventilation. They propose stages to reflect that. So stage 0, obstructive sleep apnea without hypercapnia. Stage 1, obesity-associated sleep hyperventilation with a serum bicarb that remained in the low normal range. Stage 2, normal awake CO2, but serum bicarbonate rising, reflecting a degree of metabolic compensation for overnight hypercapnia. And then stage 3, the classically defined with daytime hypocarbia, plus or minus concurrent sleep apnea, and stage 4 with significant cardiometabolic comorbidities. Its prevalence can be up to a fifth of those referred to sleep clinics, so a selected population, and does increase with increasing BMI, but it's not a clear linear relationship. So obesity is a different disease in different people, and some people may have a BMI of 70 and not have obesity hyperventilation, and some can have a BMI of 40 and have hypoventilation. But it's estimated to be as high as half of patients with a BMI in that high class 3 range with a BMI of greater than 50. The patients typically present later, so in their 50s and 60s. And unlike obstructive sleep apnea, the prevalence is more similar between genders, but females tend to present older and with more severe disease. Delays in diagnosis and misdiagnosis is really common. So often patients have diagnoses of COPD, for example, even if there's no obstruction on lung function testing. And this also definitely occurs in acute hospital settings. So Carol and I have often debriefed regarding patients we've met in the clinic, for example, who on reflection have had recurrent presentations to the emergency department, for example, with breathlessness, mild hypoxemia. Sometimes a gas is done and the CO2 is noted to be elevated, but the pH is normal or they're compensated. That is not a normal situation. Sometimes these patients are picked up in pre-anaesthetic clinic, for example, and they're referred in. Acute on chronic presentation probably occurs in about a third of patients. Maybe they're more commonly female. And typically people with obesity hyperventilation can present late, and they may present with quite advanced sequelae of the disease. The clinical manifestations can vary a bit. They can reflect the presence of obesity, obstructive sleep apnea, or of the late complications of obesity hyperventilation like pulmonary hypertension. They're not particularly specific, but these patients are usually sleepy, so they're usually hypersomnolent. They're not typically asymptomatic. Hypercarbia can induce other symptoms such as morning headaches that may lift, although that can also occur with the hypoxemia you get with obstructive sleep apnea. And they're often breathless. It is not well diagnosed or excluded by standard sleep apnea questionnaires like stop bangs and OSA 50s. It's important to consider and have an index of suspicion for patients, particularly if their BMI is in the class 3 range, if the saturations are reduced and unexplained, if they've got dyspnea that you can't explain, if there are symptoms or signs of end-stage disease, so particularly pulmonary hypertension or right heart failure should be a big red flag, facial plethora, polycythemia, and the serum bicarb, so easily seen on standard EUC panels. The gold standard for diagnosis is an in-laboratory sleep study with transcutaneous CO2 confirmed by a morning blood gas to meet those diagnostic criteria. Home sleep studies are insufficient to rule it out, but there can be clues. So if you're presented with a pharmacy or a level 2 sleep study, the more profound the oxygen desaturation, the more sleep time spent with saturations less than 90% can be a big clue. I guess the important part of this is if you're thinking that they might have hyperventilation, if you note that on the referral, that's a trigger for a higher triage category and hopefully will help differentiate these patients from the snoring sleep apnea referrals. So again, the clinical features, this is a large study, thank you, Carol, from 2014 of aggregated patients. So age in that 50s range, this cohort had slightly more males, 60%, but not as much as the sleep apnea cohort. BMI in that class 3 range. CO2 of 53, arterial O2 reduced, so 56, and that serum bicarb of 32. So it's elevated, but still sits in that, just in that normal range or the high normal range. There are some features on, so many do have sleep apnea. In this cohort, AHI was well in that severe range, although it came down, the range included moderate. And then air desaturation, 65%, with a range of 59 to 76%, and some lung function parameters as well. Lung function can show restriction due to the increased BMI, but this is really variable depending on the phenotype, I guess, or the deposition of the increased weight, whether it's chest or abdomen, but severe restriction is uncommon. So serum bicarb, I must admit, I paid very little attention to this as a medical student, and probably not until as a sleep physician did I realise its value. Maybe a little bit in intensive care, but more so later in my career. A serum bicarb, in the absence of symptoms or clinical concern, has got a reasonable sensitivity or negative predictive value, with 27 being that cutoff. So less than or equal to 27, and the patient doesn't have hypersomnolence or symptoms suggestive of hypercarbia or potentially concerning symptoms on a concerning features on a sleep study, you can be reasonably confident that that patient doesn't have hyperventilation. Those clues you can get on the sleep study if you are presented with one, so low nadir sats of less than 80% and more than 40% of time spent with sats less than 90 is highly suggestive. Bicarb can be non-specific because other things can influence or raise the bicarb, like dehydration or medications. Others can lower it, such as a concurrent lactic metabolic acidosis or chronic hyperventilation that can lower it. So important to, it's not a fail-safe, but it's a very good clue. So back to our case, this patient wasn't polycythemic, but he had features of iron deficiency on his blood film. His vitamin D was low. His diabetes control, I've seen worse, but was not optimal at 7.2%, and his bicarb was 30. And the reference range given from this lab was 22 to 32. So it doesn't flag as abnormal, but sits in that higher range. He went on to have his diagnostic sleep study, which I've shown on the left there. So this is the hypnogram or the graphic study summary of the sleep study. This is a split sleep apnea diagnostic and CPAP study. So the left from 10 p.m. to 2 a.m. was the diagnostic proportion of the night. The first panel, the hypnogram, we see lots of light sleep, so in and out of transitional, the yellow, and then into light sleep, the green. Body position largely in the supine for that duration of the night. Then we see oxygen saturation. So with the onset of sleep, profound drop in oxygen saturation. So it was 94% while he was awake, and then decreased and stayed depressed for the duration of sleep. TCCO2 is the next panel, and that rose. He actually fell asleep before it really reached equilibrium on this study night, but it was 50 at baseline, rose to more than 55 within 10 minutes of sleep onset and stayed there, and peaked at 67, so fulfilling sleep study criteria for hypoventilation. His daytime ABG in the bottom right confirms that he has met criteria for hypoventilation with a CO2 of more than 45, so it's 54 there, and a normal pH, so he's well compensated for that. And the panel under that is our CPAP pressure. So at 3 a.m., CPAP was applied due to this clear diagnostic portion of the study and rapidly titrated up to 19. But despite that, the CO2, as you can see in the panel above that, didn't improve. But he did get a bit of improvement in his sleep architecture and a nice big period of REM sleep, that red bar across the top. Oxygen remained depressed. In the respiratory event panel, we can see the second line down. I'm not sure if you're able to see my pointer. The obstructive events following application of CPAP here, then converted more to hypopneas and reduced in frequency. This is sleep apnea is becoming controlled. However, the oxygen and carbon dioxide aren't. He went on to have lung function, and these were actually within normal limits. So that excluded COPD. He did not have that diagnosis. His diagnosis was that of severe obstructive sleep apnea and obesity hyperventilation. While he had intermittent tramadol, I didn't think that was of major clinical significance. And not everybody fits neatly into boxes. So you have to have a degree of, I guess, clinical acumen about whether or not you think he completely fills criteria for obesity hyperventilation. Other causes of hyperventilation to consider or exclude. So obstructive lung disease, restrictive lung disease, so neuromuscular weakness. So having a think about, and particularly in those without obesity, myositis, for example, myopathies. If a patient has had difficulty with their grip strength or getting up and down from the toilet or seated, for example, should be a real red flag for neuromuscular weakness. Electrolyte disturbances, particularly magnesium and phosphate, when severe, can impact ventilation, hypothyroidism, and chronic sedative use. So why does obesity hyperventilation matter? Well, probably alluded to it already. This is a steadily progressive disease, and it's a state of respiratory system failure. Untreated, it will progress, and it can include end organ damage and death. Comorbid pulmonary hypertension is really common. So in a relatively small cohort, but 77 patients who had obesity hyperventilation and underwent an echo, 2/3 had at least moderate pulmonary hypertension, and it tended to be more severe in women. Patients with obesity hyperventilation use the healthcare system more, they present more, they cost more when they come, and they're hospitalised usually for longer. They're more likely to need intensive care support or be intubated, and there are definitely anaesthetic safety implications, particularly if there is pulmonary hypertension. And the mortality is high. So if untreated, 1/3 will die within 3 years. And if you're someone who presents with acute on chronic respiratory failure, you've got a mortality approaching 20% at 1 year. So the management, diagnosing it is probably one of the most important things because then one can get onto treatment. The gold standard treatment is positive airway pressure. And for some, CPAP alone, so treating the upper airway obstruction component, is enough to rebalance the system and allow the body to compensate and no longer hypoventilate overnight and then during the day. But many of these patients, particularly if they are presenting acutely, will require bi-level positive airway pressure. Treatment of obesity as the underlying cause is also important. Aggravating factors, so sort of basic safety things, particularly when patients are presenting acutely, and to be aware of, trying to avoid hyperoxia, so very similar to the teaching for COPD patients with chronic hypercapnia, targeting saturations in that safe range, 88 to 92, and confirming whether or not there is CO2 elevation. Trying to avoid, if at all possible, sedatives or psychotropics because it's going to make it worse. And I have seen this once in action, I guess, in the intensive care unit with a patient in a furosemide infusion. who had significant fluid overload, developed contraction alkalosis, rise in bicarb, and then compensatory respiratory acidosis, so it tipped the balance into overt respiratory failure. Treatment with non-invasive ventilation or positive airway pressure improves this condition. So it's really important that we try and diagnose it. And the earlier we diagnose it, the better. But you can reverse some of those adverse physiological changes by treating the hypoventilation. And survival improves to similar to that of patients without hypoventilation. So back to our case, he returned from his original diagnostic split to CPAP study and had a formal bi-level titration sleep study. So very similar hypnogram at the top, but you can see a much more normal sleep architecture with all the different stages of sleep. Again, largely supine, overall significantly improved oxygen saturations compared to the first sleep study. CO2 had come down by the end of the night, and the morning blood gas would actually induce a slight alkalosis due to normalization or lower CO2. Again, improvement in the obstructive events, so few hypopneas and reducing in frequency as the night wears on. 8% of this night was spent with SATs less than 90%, which was far better than his original. So his sleep disorder breathing was treated, and we saw him over the next couple of years in follow-up. He'd actually really embraced his dietary advice. He began walking more with his carers. He underwent a medically supervised VLED, and he transitioned to his new diet following that, so was able to maintain and continue his weight reduction. And he opted for and was supported by his family in a calorie-controlled meal delivery option. I think it was light and easy in this case. He had semaglutide for his type 2 diabetes, although supply was interrupted over this time. He did not want to pursue metabolic bariatric surgery, and ultimately he was happy with his progress. He'd had 25% total body weight reduction of 53 kilograms. He still had class 3 obesity, but his health was much better. And I clipped my last letter where I saw him walking down the corridor, very different to when he first presented, without any evidence of dyspnea, carrying his walking stick but not using it. So it was really nice to see. And he also safely underwent a colonoscopy. They found a tubular adenoma and polyps, which explained his iron deficiency. So in summary, sleep disorder breathing is really common, particularly where there is obesity, and that increasing weight is a major modifiable risk factor for complicated sleep disorder breathing. The presence of obesity hyperventilation has really significant consequences. It's important to actively screen and think about this, and so we can seek the diagnosis. If the saturations are reduced and it's not easily explainable, or if you think it's explainable by COPD, for example, but you don't have confirmatory testing, it's worth thinking about. What is the serum bicarb? Does that help you? Definitely, if there's evidence of end organ failure, such as pulmonary hypertension or right heart failure, that's an important red flag. And if you bring those concerns to our attention on referral, then they should be triaged appropriately and get earlier access. And obesity hyperventilation can be treated with improvement in outcomes. So I must have been nervous because I spoke to that much more quickly. And so I've got plenty of time left. But I'm not sure if there's any questions or if we want to save those to the end. References.
Thank you so much, Dr. Inman, for that presentation. We don't have any questions yet, but please, if you have any along the way, you can pop them in the Q&A box at any time, and we'll address them all at the end together. I'd now like to introduce our second speaker of the night. So our second speaker tonight is Dr. Carol Huang. Carol is a respiratory sleep medicine and general internal medicine physician, and she works as the director of respiratory and sleep medicine at Canberra Hospital and privately at RSCM, where she consults on sleep and obesity medicine. Her main research interest is medical obesity management and non-invasive ventilation and pulmonary physiology. Carol also has her SCOPE certification. Please join me in welcoming Dr. Huang.
Thank you for your kind introduction, Michaela. And I'm just going to try to share my screen and we'll go from there. Can you see my screen?
Yes.
Yeah, good. Okay. All right. So today, for the final talk of this webinar series, I thought what I'll do is I'll show you some cases of when PEP therapy is not working properly, and what can we figure out by having a look and see what the machine says. Okay, so the learning objective for today's talk is hopefully by the end of it, you'll be able to describe the type of information that you can get from a CPAP or a non-invasive ventilation device or a BiPAP machine. And hopefully you'll have a reasonable understanding of the steps required to evaluate a patient who present with problems associated with use of their positive airway pressure device. And also to identify from the device downloaded information what the potential issues might be and whether they should be referred to a sleep physician for further evaluation. Okay, so these days with modern CPAP machines or BiPAP machines for that matter, they now all have a download function. But the reality is there's actually no textbook out there to show you how to read these downloads. And the question is always, does the machine always tell the truth? And what can we actually learn from these machines? So there are a few different types of machines and they do slightly different things. And when you actually read the correspondence from a sleep physician, they may tell you the patient could be on APAP or on CPAP, or sometimes on BPAP or BiPAP or non-invasive ventilation. So we'll just go through the different modes and what they actually do. So in the old days, when CPAP first came around, this is the most common way that we deliver positive airway pressure to our patients with sleep apnea. And it is a constant pressure. So the doctor sets a pressure, and in this case, it's running at 8 centimeters water, and you run the same pressure all night. So that's the traditional fixed pressure CPAP. Now, it's probably now maybe about 15 years ago or so, the companies started making something called the APAP, which stands for automatic positive airway pressure devices. And these devices have a computer chip in it, which detects the level of obstruction, and use a computer generated algorithm to actually adjust the pressure of the device. And the thing to remember is that these algorithms are proprietary and they actually differ from company to company. So if a patient buys a ResMed machine, but the machine is broken and they swap onto a Fisher and Paykel machine, for example, although the pressure settings may be the same on APAP, but the way the machine responds can be quite different. So this is an example on the left here of how the APAP machine will respond. So if the respiratory flow is intact, then the pressure stays at probably the minimum level. And then as the patient starts to develop some obstruction, what then happens is the auto-set algorithm in this case starts to increase pressure. But this graph is taken from the ResMed devices. And what you can actually see is that even within the AutoSet machine, what they have done is they've got two different types of algorithm. So you could either set the patient on AutoSet or you can set them on AutoSet for her. And you can see that if even with the two different algorithms of AutoSet, you can actually see that there's a difference in response to the same obstruction. So it is important to actually understand that algorithms can be quite different, but the idea is overnight, depending on the level of obstruction, you end up with a fluctuating pressure over the course of the night, and perhaps the patient's in REM sleep and have more obstruction here, so the pressure requirement is higher. And then we come to what we call non-invasive ventilation, which is sometimes written as BPAP or BiPAP. And with non-invasive ventilation, the main use of this is for respiratory failure due to hypoventilation. And when you prescribe ventilators like this, essentially there are two pressures required. So there's a minimum pressure that's sort of maintained throughout expiration, and that really is there to keep the airway open. And then with inspiration, you actually provide an additional pressure, which leads to inspiratory assistance. So during exhalation, the pressure is set on the EPAP. And then as the patient breathes in, the machine should actually respond to the respiratory effort. And then the pressure then increases. And then the patient continues to breathe in until they stop the inspiration, and then the device should actually be able to detect that and then drop the pressure back down to EPAP again. And they're depending on the mode of ventilation. Sometimes some of these machines can also provide a backup respiratory rate in the case the respiratory rate is dropped too low. Now, I just wanted to show you this paper, which I wrote quite some time ago now. I think this just shows how old I'm getting these days. But the important thing to realize is that these machines, while they give you all sorts of numbers, we have to remember they can lie as well. They are not always completely truthful. And I'll show you some of the data that we have discovered in this paper. So this was work that I did when I was in Western Australia, and we included 190 patients, and it's a retrospective consecutive series of 190 patients who came to our laboratory in St. Charles Gardner Hospital for auto titration studies. So the patients were put on auto titration, and we let the machine do the work during the night. And at the end of the day, we found that only 58% of all the patients actually achieved optimal or good control of their sleep apnea, which was defined as the apnea-hypopnea index of less than 10 per hour, or at least a 50% reduction in AHI if the diagnostic AHI is less than 15 per hour, so at least 50% reduction in AHI if they have mild sleep apnea. So what does this tell us? It tells us that actually the automatic algorithm does not actually work for everybody. And so how does the device generated the apnea-hypopnea index actually compare with the simultaneous polysomnograph apnea-hypopnea index? So if you look at the average AHI that's derived from the device is very, very similar to the average AHI derived from the polysomnogram. But the Bland-Altman plot on the right here shows there's actually a significant scatter. So there are these patients out here where the device AHI significantly underestimate the actual AHI. And then there's these patients down here where the device AHI is higher than the AHI that we get during a sleep study. So although the average is okay, the agreement between the two measures can actually be quite poor. And at the end of the day, we found that in 49 out of 171 patients, the device doesn't always categorize the residual apnea-hypopnea index correctly. So when the device actually says that the titration, sleep apnea is well controlled, 30 of these patients actually did not have adequate control of their sleep apnea. And when the device says that the sleep apnea is not controlled, 19 patients actually, according to the sleep study, looked like they had really good control of their sleep apnea. So if you use the device download as confirming that you have adequate titration of your pepper pressure, then that will give you a sensitivity of 82%, but specificity of only 56%. So does that mean that we're not going to use the device? Is the device download actually useful? I think without a doubt that the device download is useful, but we just have to remember that the machine does not always tell the truth, but it is useful in that we can actually tell how much our patients are using the device, what's their adherence like. We have a reasonable idea whether their mask is leaking or not. And sometimes with this residual apnea hypopnea index that's displayed on the machine, you just have to have a healthy skepticism about whether you are going to believe the number. And remember, if your patient cannot sleep at all, you will have a very low residual AHI, because if they're not asleep, they cannot have sleep apnea. So that's something to think about. So I would advise that you use this clinical information. Use your clinical information in conjunction with what you're seeing out of the device, rather than just taking the device download in isolation. And this is quite important. So these are some of the steps that I think are important, that if you have a patient that comes into your consulting room telling you that they have a problem with their machine. So I always start by asking these questions about who, when, and what. So who is the patient? What's their medical background? Do we have a previous sleep study that we can look at? Why did they go on the machine to start with? When did they first start using the machine? Did the machine ever work? Was there a sleep physician involved in the diagnostic process? Who decided on the prescription? And when did the current problem start? The other things to think about is what machines are actually in use. Take a look at the model of the machine, which is very important. Now, what do the equipment associated with CPAP look like? Is the mask in good condition? Are there holes in the tube? Just this week, I saw a patient come in with a mask that's actually covered in black mold, and clearly that's not kind of conducive to CPAP therapy when you have a mask that's not clean like that. So something to think about. And I just wanted to point out that if you have access to the machine, it's really important to take a look at that machine and take a look at that equipment, and that may give you some clue on what sort of therapy your patient could be on. So I just wanted to show you, so this is an example using the ResMed device, which is quite commonly seen around Canberra. And on the left here is the device called the AirSense Elite. So the Elite, this device only delivers a fixed pressure CPAP, so it's not possible to do APAP using the Elite. And then you can also have the AutoSet machine, and on the machine itself, it will say it's AirSense 10 or AutoSet, but you can see they have the same. They have the same color. They have the same look to it. And if you don't actually take a note, you may not realize the difference. And what's more is sometimes you'll have a patient that brings this machine in. And this machine has a slightly different color scheme, but essentially has the same casing, look the same. But if you have a look here on the model, then you realize that the patient is on Loomis 150, and this is in fact a bi-level ventilator. And if you have someone who brings a machine that looks like this, then you have to assume that they are on bi-level ventilation and they have hypoventilation. And if you were to give them sort of painkillers or sedatives, then there's a chance that they will require increased pressure in order to control their underlying condition, or they'll go into frank respiratory failure. So if you see one of these machines, then we have to be quite careful. So now what we're going to do is we're going to show you 3 cases this evening, and just to give you a taste of the sort of things that we can find out from the machine and what we did in order to troubleshoot the problem. So the first case is the case of Penny. So Penny's a 65-year-old lady, And she has a background of type 1 diabetes. She also has hypothyroidism, reflux, and she has depression. So she first came into the clinic with severe sleepiness, and her Epworth sleepiness scale is 21 out of 24. And she has class 1 obesity. Her body mass index is 32.2, and she weighed 90.8 kilograms. So we did a sleep study and found that she has severe obstructive sleep apnea with an apnea-hypopnea index of 36.5, the lowest oxygen saturation 71%. So after this was done, Penny went to a pharmacy and got herself onto an APAP. And then turned up to the clinic and said, look, you know, I had the CPAP now for 6 weeks, but I still feel totally unrefreshed, and I'm waking up an awful lot. The machine is quite noisy, and the mask is leaking, and her Epworth sleepiness scale has slightly improved to 20 out of 24, but clearly unsatisfactory, you know, response to CPAP therapy so far. So these are some of the options of what you could do. And I wanted for you to think about it as we go through some of the information that's available to us if we ask for a CPAP download, so that you can get a taste of what the sort of thing you could do. So these are some of the options. So we'll start by having a look at the summary stats that came out of the machine. So we can see that this is for this download is for a period of about 20 days. And the device is an automatic machine. And the therapy mode is set on auto set. So this is running as an automatic machine with a minimum pressure of 6 and maximum pressure of 16 centimeters water. These days, the CPAP machines typically have a ramp, so it can start on a low pressure, and then as the patient is falling asleep, the pressure then gradually increases, and that's set on 20 minutes. Now, Penny's been using it for 20 days so far, and you can actually see that the average usage per night is 5 hours and 51 minutes. So she's definitely using it quite a bit. The machine tells us that the pressure she required is 15.8. So that's very close to the maximum pressure. But it says the residual apnea-hypopnea index is 1.2. The other thing this machine can also tell us is how much leak the patient's having. And this, in fact, says most of the time the median leak is 2.4 liters per minute, which is actually quite good. And 95% of the time, the leak is 12.6 liters per minute or less. And generally speaking, we would sort of consider a leak of less than 24 liters per minute as being a reasonable mask fit. So here are your choices. So your choices are, we can go, what would you do next? You could sort of say, perhaps the maximum APAP pressure is very close to the 95th percentile pressure, and maybe the pressure titration is topping out because we put a limit here of 16. So therefore, that's just increase the maximum pressure in order to allow the machine to deliver more pressure. Or you could go B, well, I could reassure the patient and say, hey, look, the machine says everything is working fine, and the apnea-hypopnea index is 1.2 per hour, so there's nothing to worry about. C, the next option is I'll get Carol to come and fix it. Or D, what we could do is tell Penny that, you know, you need to use the machine a bit more. You're only on 5 hours and 51 minutes, and maybe your sleepiness will improve if you use the machine a bit more. So these are the options available, and we're going to go through some of the other information that might be available to us. And then at the end of that, we're going to get you to vote, and we're going to do a poll on what you would do next. Okay, so the next bit of information that you could get from the machine is you can actually get a night-to-night summary of the apnea-hypopnea index. And you can see here, the machine thinks that the apnea-hypopnea index is quite low. And she's definitely using it plenty. Some nights she will have 2 blocks of usage, and other nights it's being used uninterrupted. And sometimes she does seem to go to bed quite late, like in the order of 2 a.m. in the morning, and then she gets up at about 10 or 11 a.m. So I'm not sure, looking at this, whether that's real, or one will have to check and see if the CPAP machine clock is actually adjusted properly. And if we have a look at one of the nights that Penny has been using the machine, you can actually get a profile of what the pressure looks like, and at the same time have some understanding of what the leak is like. So on the 30th of April 2023 is the example we have today. And what you can see is this machine got started at about 2:30 in the morning, and went through a period where it went up. And then at around 4 o'clock, just before 4 o'clock, in fact, 3:30 or so, the pressure is very high. And in fact, it's hitting the maximum pressure that's been set on the automatic. And you can see most of the time she doesn't have much leak, but in the early hours, by 9 o'clock in the morning, she's starting to leak quite a bit before she got up. So that's the information that's available to everyone if you ask for a download of the device. So what would you do next? So I'm going to ask Kuno to put up the poll, and I'd like or everyone to pick an option. Okay, so 5 more seconds to vote, and then we're going to have a look and see what happened to Penny next. Okay, so we're going to end the poll now, I think. So yeah, so the about 27% of you say that the apex pressure is very close to the 95th percentile pressure, and that's just increasing the maximum pressure, so give Penny more air. 9% of you said that look, that's the machine says that the AHI is very good, so therefore it's fine. 55% says, oh, let's get Carol to fix it, or maybe let's get Deb to fix it. And 9% of you said that, look, if you use the machine a bit more, then the sleepiness will improve. It is true that the more you use the CPAP, the sleepiness will usually improve, but in this case, we have a severe sleepiness. So let's have a look and see what I did. Okay, so let me get out of here so I can show you what we did. Okay. All right. So in fact, Penny came. I looked at Penny, and Penny's not the biggest patient I have in my clinic by a long way, but the pressure of 16 is actually very, very high relative to her body size. So I decided that actually she needs to have a sleep study, and let's just have a log, because I honestly did not think she would require that sort of pressure. So she came in for a sleep study. And in fact, at a sleep study, we just started the CPAP at 8 centimeters water. And over the course of the night, we actually looked at the amount of sleep she had, and try to actually see if we can identify a good spot in terms of her CPAP pressure. And what you will see is that with the apnea-hypopnea index, it's actually invariably good, even on CPAP as low as 8 centimeters water, and increasing it didn't really make an awful lot of difference. The oxygen level is quite good, the carbon dioxide level is quite reasonable, and she is not waking up an awful lot at all. So now knowing that, we actually put Penny on a CPAP at 8 centimeters water. And we have to remember the higher the pressure, the more problem you'll have with the leak, because the small leak under high pressure turns into a large leak. So we had Penny on 8 centimeters water, and she came back at 6 months and said that her sleepiness was much improved. And in fact, her average CPAP usage at this stage has increased a little bit to 5 hours and 29 minutes. And the average apnea-hypopnea index, according to the device download, is actually 2.5 per hour. And the time in large leak is 26 seconds per hour. So this is actually an example of failure to auto-titrate. And there's actually no way of knowing that the machine is not titrating properly unless you do a polysomnogram. So the machine is over-titrating, and it's actually probably causing more awakenings. So this is an example of when APAP doesn't always work. Okay, so now we're going to look at the second case, and the second case is Peter. So Peter comes into the clinic, he's 59 years of age, and then he said that, well, he went to the hospital and he was admitted with COVID-19. So this is a couple of years ago now. And they wouldn't let him leave the hospital until he promised that he'll buy a CPAP machine. But so he bought this CPAP machine, and he was unable to use the machine. And he tells me that he has been short of breath lying in bed. So he's actually been sitting up to sleep for several months. He has a long history of snoring, and in terms of his medical history, he's been investigated for polycythemia. He's got a background of a common variable immunodeficiency. He has hypertension, he has reflux, and he has gout. And Peter is a little bit bigger than Penny, so he's 159 kilograms, and he's got a body mass index of 46. So he has class 3 obesity. And he went on to have he had a sleep study, which was done before he got to come and see me. And the sleep study actually showed an apnea-hypopnea index of 38.4. And before the sleep study, this was actually being ordered at Canberra Hospital. Before the sleep study, he had a capillary blood gas, and that showed a blood gas of 44, and the lowest oxygen saturation in his sleep study was 73%. So I persuaded Peter to use his own APAP machine, which on the setting that he has been set up for. And he came back after months and told me that he had no improvement in symptoms. And let's have a look and see what his machine is doing for him. So again, this is a 1 month download, and his machine is set to have a minimum of 6 centimeters water and a maximum of 20 centimeters water. And again, they've put a ramp of 20 minutes to allow him to fall asleep. And what you can actually see is during these 31 days, the average daily usage is a little bit on the low side at 3 hours and 12 minutes, but he did try, and I think the usage is low because out of the 31 days, he didn't actually make a start on 12 of those days. But overall, he did come back after 99 hours, 99.5 hours of use over a month. So it gave me some information to look at. The pressure required is about 15.7 or less, 95% of the time. And he has a little bit more leak compared to Penny. So his mask is leaking at 28.8 liters per minute or more at about 5% of the time. But the median is, again, quite reasonable. And the machine says the residual apnea hypopnea index is 4. So what would you do next? So here are some of the options that of the things you could do. We could sort of say, oh, look at the APAP pressure is very close to the 95th percentile pressure. And like a Penny, I'm going to increase the APAP pressure. Or you could sort of say, oh, well, look, the machine says everything is working and the apnea hypopnea index is 4 per hour. Or we could sort of say that, look, need to get Carol or Deb to come and fix it. Or we could sort of say that, look, you just need to use your machine more. And if you use your machine more, your symptoms will be better. So similar sort of information that we can get. So here you can actually see that actually Peter did use it quite a lot because we took 1 month's average. And so the average hours is reduced. But what you can actually see is most of the nights from about the 29th of April onwards, he actually did have some decent nights and of usage. Sometimes it was a little interruption in the middle, but most nights he did actually make a start every night for a period of about 15, 16 days. And the machine is consistently saying that the apnea hypopnea index is quite low and definitely less than 5 anyway. And this is kind of and this is just another way of looking at the usage. So the line represents a usage of more than 4 hours, which is considered to be adherent to the PAP therapy. And you can actually see that for most of the nights, he's actually using it for more than 4 hours if he did make a start altogether. And this is some of the same information that we saw from Penny as well. So the pressure actually goes up when he puts it on, it goes up quite quickly. And over the course of the night, goes up and down a little bit. And here he had a little bit of interruption. And then the ramp starts again, and then it goes up and down. He has a little bit more leak compared to Penny, but again, most of the time, it's less than 24 liters per minute with a few big spikes. So this is what the machine is telling you. And after looking at that, what would you do next? So we're going to run a poll for the next 20 seconds or so, and perhaps you can tell me what you would do next. Kuna? Okay, so maybe another 5 seconds to vote, and then we're going to have a look and see what I did next. Okay, so that's in the poll here. And I think we have 9%, 10% telling me that the APAP is a bit too close to the 95th percentile pressure, and that's increased the APAP pressure. But in fact, the Peter is actually already on 20 centimeters water, and that's as far as you can go. You can't go any higher than that on the machines, on the APAP machines anyway. And 20% of you said that maybe we should just reassure Peter AHI is 4, everything's working fine. 60% say, oh, Carol and Deb can fix it. And 10% of you sort of says, well, you're not really that adherent to the machine, and maybe your sleepiness will improve if you use it a bit more. Okay, so let's stop sharing and we'll get back to our presentation here. Okay. So this is in fact what I did. Try again. All right. So I actually ended up ordering a sleep study for Peter as well. Because I actually thought that he was using it, and for the 2 or 3 weeks before he came to see me, anyway, he did actually have some reasonable usage. And so we saw Peter here, and Peter sort of came in for the sleep study, and during the course of the night, what happened was that the CPAP was started at 9 centimeters water, and we gradually went up to about 13 centimeters of water. And as you can see, as we went up under pressure, the apnea-hypopnea index drops. And actually at 13 centimeters of water, his apnea-hypopnea index is within the normal range. But the issue here is that as the sleep study went along, you can see his average saturation is actually not great. And his transcutaneous carbon dioxide level is actually persistently high. And so this is actually a patient who's got sleep-related hypoventilation, and by increasing the CPAP pressure, that didn't the carbon dioxide level didn't drop at all. So Peter actually needed to go on a ventilator. A CPAP is inadequate to treat his sleep-related hypoventilation. Okay, so last one and final one. So the last patient is Malcolm, and Malcolm's an old friend. He is now 92 years of age. And I had previously seen him in 2011. And at that time, actually, no, that's not quite right. I had seen him some time ago, and he came to me already on CPAP after a sleep apnea that was diagnosed in Queensland with an apnea-hypopnea index of 49. And he has been on CPAP at 14 centimeters for some time. And then he last came to see me in 2016. And then after that, he had a couple of appointments, but he just didn't turn up. So now in 2023, I saw Malcolm for the first time, some 7 years later. And over this time, Malcolm had developed a new atrial fibrillation, which started about 2 years ago. And he has a prostate problem, and he also has asthma and glaucoma. And Malcolm weighed 88 kilograms with a body mass index of 30. And Malcolm comes along and tells me, look, my sleep is terrible at the moment. I still use the CPAP machine, but I can only sleep for 4 hours, and I get up several times to go to the bathroom, and I'm getting pretty sleepy during the day. So we downloaded Malcolm's machine, and Malcolm's on a Philips machine, so they look a little bit different. And as we go through some of the information that's available from his machine, I want you to consider which of the following is true. Okay, so what you can see is this is a schematic diagram showing you what Malcolm's doing. So for most nights, Malcolm is using his CPAP machine, and you can see, and there's the blue bars with the total number of hours and minutes, on it. So here we, ranging most nights when he makes a start, you're looking at, more than 7.5 hours. There's a short day there, a couple of days where he missed out, but there's some days where he's using it for 9 hours a night. And what you can also see is some of these nights are fragmented, and they come in several different fragments. But generally speaking, it looks like, he gets up out to the loo, and he comes back on the CPAP, and off he goes again. But some nights are definitely looking rather fragmented, like this Sunday here. And you also get a compliance summary on the Philips machine. So they look a little bit different, but they essentially have the same information here. So here is a 30-day summary, of which Malcolm used the device for 28 days. The average usage on all days is 7 hours and 46 minutes and 21 seconds. And he has used his device for more than 4 hours on 93.3% of the night. And the Philips device gives you a tiny large leak, and that averaged 2 minutes and 24 seconds, which is quite reasonable. But it's telling us that the AHI is 29.1, and he's still on his CPAP at 14, just like when I last saw him in 2016. So which one of the following is true? Has Malcolm got increased sleep apnea severity and need to have his CPAP adjusted? Or is Malcolm having problems with insomnia and let's give him a sleeping tablet? Or has Malcolm got insomnia and needs a CBTI? Or perhaps Malcolm needs to use the device more, and if he uses his device more, his sleepiness will improve. Or perhaps Malcolm needs to see a sleep doctor because he has a complex sleep apnea. So let's do a poll on this and see what you guys think. Oh, okay, before we do that, I'll just show you one of the nights. So this is what one of the nights actually looks like. So on this particular example, this is done on the 12th of February, 2023. You can see that the pressure starts the same at 1409. So it's on fixed pressure CPAP. And the machine actually sort of shows that there's quite a range of respiratory events. And it sort of helpfully tell you that it thinks some of these are obstructive apneas, some of them are central apneas, and then there's this thing called CSR, which stands for Cheyne-Stokes respiration, but there's also vibratory snore. And then it sort of tells you that, that overall AHI is 19.3 on this night with 21.2% Cheyne-Stokes respiration. And the mass fit is normal throughout the night. There is not an awful lot of leak. So now knowing this, which one of the following is true? And let's run the poll again. Kuno? You're going to run the poll? I can't see the poll. Can anyone see the poll? Oh, there it comes. Yep. So let's give you 20 seconds to decide what you want to do with this. Okay, last chance to vote. All right, we might end the poll there. So 13% of you says that perhaps Malcolm should consider using it a little bit more. And 86% says, oh, well, look, probably should see a sleep doctor because he has a complex sleep apnea. Okay, so let me show you what I did when I saw Malcolm. Oh. Okay, so what I did with Malcolm is I ordered a sleep study for him just to see what's actually going on. And what we have actually seen is when we started him just on CPAP, what's actually happening is his apnea-hypopnea index is quite high. And then as we sort of went up a little bit, we went up a little bit more, the apnea-hypopnea index remained quite high because he has quite severe Cheyne-Stokes respiration. And then we attempted to add some oxygen, inject some oxygen into the CPAP to see if that will improve. And one would argue that perhaps this is looking reasonable with 9.4 centimeters of CPAP with 1 liter of oxygen. But eventually, he tossed and turned and had more problems, even though we increased the oxygen and there's still a bit of apnea-hypopnea index. And in fact, Malcolm did eventually end up on adaptive servo ventilation, where he slept for 2 hours and his apnea-hypopnea index is 0, and you can see his arousal index drop down to 12 per hour. And there's not an awful lot of leak. Now, this was instituted by my sleep scientist, but that was not actually really necessarily in the plans that I had for Malcolm. So essentially, his sleep study showed complex sleep apnea with both obstructive events as well as Cheyne-Stokes respiration, and it didn't seem to respond terribly well to CPAP therapy or CPAP plus oxygen. So the scientists started him on adaptive servo ventilation. And then I sort of looked at it in the morning and go, oh, but with the SERVE-HF study, it actually suggested that if you have a patient with heart failure with reduced ejection fraction, you start them on adaptive servo ventilation, they have increased mortality. And so anyway, so I presented all of this information to Malcolm, who's 92 years of age, and his wife, and sort of said, look, this is what the studies show. And Malcolm turned around and told me, look, doctor, the ability to sleep is priceless, and he didn't really care that much about the mortality so long as he can have a good night of sleep. So the two of them decided they wanted to trial adaptive servo ventilator, and I helped them rent a machine for months just to try to see how it feels. And this is the download that I get from Malcolm after about a month. So what you can actually see here is since he started using his ASV, the duration of use has increased quite significantly, and he does not wake up very much at all. Still has a couple of naps over the course of the day, and he used his machine for 2. But the average daily usage is 8 hours and 10 minutes per night, and he doesn't have much mass leak at all. And so he's on EPAP of 9.4, and with adaptive servo ventilator, basically what the machine does is in times of hypopnea due to Cheyne-Stokes respiration, it automatically increases the respiratory support and overall try to even out that respiratory effort. And Malcolm and his wife sort of agreed that actually he just looks better and feel better, and his sleep quality is much improved. So this was what was written by my registrar, and my registrar said that he was pleased with the data. But we then said again that look, in the literature, this may be associated with increased mortality with heart failure. And they say they understood, but they're going to keep going because it's providing clear benefit. And so that's all I have for you, just to give you a taste of some of the information that you can get from a PEP machine. And if one of your patients turn up in your consulting room saying that I have a PEP machine that doesn't work, perhaps that'll give you some framework of trying to understand what might be happening. And over to you, Michaela.
Thank you, Dr. Huang. We've already got one question in the Q&A, but to everybody else listening at home, if you have more questions, make sure you pop them in the Q&A now. So the first question says, for a private driver's license renewal, some patients have been given a diagnosis of sleep apnea and have had a past history of a trial of CPAP, but were intolerant and then had no further follow-up with a sleep physician. Can you advise how we can manage or assess the driver for their private license renewal? Should they be referred back to a sleep physician to reassess? And how would this change if it was a heavy vehicle driver?
Is this a question for me, or is this for Deb?
I will open it up to either of you.
Do you want to have a go?
I can have a crack, Carol, but I think these driver's licensing ones, I also find difficult in practice. So it's probably nice to have a couple of opinions. I would refer to the driver's their guidebook. Sorry, I just can't remember the name of it off the top of my head now. The handbook. But the wording actually talks about a sleep apnea syndrome. So I think having a degree of knowledge about what that sleep apnea diagnosis was. And I think sleep apnea syndrome encompasses the symptoms that go along with it. So just having a sleep study with an AHI of 10 or 15 or 20 is probably not enough for me to say, they can or cannot drive. I need a lot more information. Definite red flags, so things that would say they should absolutely be followed up by a sleep physician, are the presence of severe sleep apnea, symptoms, so particular somnolence, so an Epworth score that is elevated, and especially if it's 15, 16 and above, because the risk of accidents increases significantly over that. If there are relevant comorbidities, and if you've got the capacity to have a little talk about the trial of CPAP, what was that context like? Is it potentially, some of those things that Carol talked about, failure of titration of APAP? It didn't give them symptom resolution. That's why they didn't stick with it. And they still have symptoms. There would all be reasons to follow up the sleep apnea independent of the licensing requirement. But I think, that would be a really good, reason to refer them on. Heavy vehicle drivers, I think, are a bit different, and I would refer all of those patients for a sleep assessment, in my opinion. What do you think, Carol?
I think, at the end of the day, what we need to actually remember is we are not the one who says the patient can or cannot drive. Our role really is to decide whether the patient fulfills the medical standards for driver's licensing. And I'm not here to stop someone from driving, but we need to actually advise them whether they fulfill the medical standards for driver's licensing. And if not, then in most jurisdictions in Australia, with the exception of, I think, South Australia and Northern Territory, there is the requirement to report actually lies within the patient. So our job is to tell the patient that it's their responsibility to report, unless you think someone is seriously dangerous. And then you then look at the RTS medical standards for driver's licensing. And I'm just trying to see if I can find it here. And I think it sort of says that you have to have symptoms of sleep disorder breathing and excessive daytime sleepiness, or have to have a diagnosis of sleep disorder breathing. And then if you do that, then they do not fulfill the standards for unconditional licensing. But if they then have treatment, they may actually fulfill the conditional driver's licensing, subject to annual review or biannual review or something like that. So, you would have to actually have a good look at what the standards actually say. And often I give the patients a copy of the standard and say, this is what it says. And, and we just following the law, we advising the patients against the standards. And at the end of the day, that's all we can do. And if your patient disagrees with you significantly and they want to do something else, then you always have the option of referring them to the fitness to drive clinic, which is run at the Canberra Hospital. And they can have a full assessment by people who do that all the time, and then form a formal opinion.
Thank you. We've got a second question in the chat. It says, should there be greater regulation of selling CPAP devices without proper medical evaluation of the best settings, rather sending the client off with a device having 60-20 pressure set and let them work it out?
I can have first crack at this one too, Carol. But
Oh.
I guess, being a sleep physician, I'm heavily biased, but, I think there's an inherent conflict of interest if you're diagnosing and then selling the treatment for the condition. and potentially not having the ability to troubleshoot, just like those things that Carol mentioned. And that's my opinion. I think ultimately there is a section of the market or a section of patients who actually can do well with this pathway, and it serves a gap, and there is a need for an increased capacity for us to see, patients with suspected sleep disorder breathing. And that's potentially part of the reason why this evolved. But I think it is not well regulated. And I mean, Carol and we probably see patients very frequently who've fallen through these cracks. So those with hypoventilation for whom the CPAP hasn't worked, who've spent money on or have been told they needed CPAP, with unclear diagnostic, studies or those sorts of things, inappropriate machines being purchased. So, APAP for someone who's clearly got hypoventilation when you meet them for the first time. But I don't know how much traction we're going to have on that, because there's still a huge discrepancy in demand versus supply. I think it would be great to be able to work in partnership and to be able to have a relationship with CPAP providers where they feel like they can contact you, that they're aware of the things that should be flags for them to flag for patients to come and see their GP or a sleep physician. What do you think, Carol?
Look, I think, for a lot of patients, that APAP works okay. And if people have a consistent sort of sleep study findings, and they have improved symptoms, and the APAP download says everything is good, then in low likelihood everything is good, and there's probably not much more that one needs. But by the same token, when I prescribe a CPAP machine, I'm prescribing something that the patient is going to use for the next 25, 30, 40, 50 years. So, this is likely to be a lifelong treatment. And if we are actually committing our patient to treatment like that, I think every patient deserves to have one proper look and have a proper diagnosis. And if we're going to subject our patients to CPAP therapy, and I think we have a responsibility as healthcare providers to make sure that the CPAP machine is actually going to give the best result we possibly can. And that sometimes is where the patients are left shortchanged, when they are going through providers who may or may not have any significant training, who tell the patients that, look, the AHI is fine on the download, so therefore the problem is you, not the machine. And I have just shown you that the problem is not usually usually the patient, or if it's not working out, usually the patient knows it's not working out, and we need to do further investigation. And that's kind of my view of the world. But there's some situations where the CPAP providers have done good work, but they need to understand their limitations. And then you also have people who are purchasing their CPAP machines on the internet. Now, that's without any advice from anybody, and they just have one posted to their house, and they're hoping that it's going to work for them. And that's obviously less than satisfactory. I did have a farmer came in the other day, and I sort of say, oh, okay, so how long have you been using this machine? And then he told me, oh, I've been using it for about 3 years. And where did you get this machine from? Who prescribed this for you? And then he told me that his neighbor did without a sleep study. I said, oh, why would you do that? Said, well, he was buying one for himself, and he thought it was a good idea, so asked if I wanted to have one. So he bought one too. This is a true story, and but then, so I think I do believe everyone deserves a proper diagnosis, because you're going to be using this for years to come. And so this is what, I think that's kind of important. Now, getting back to the fitness to drive sort of thing, I have the medical standards up here. If I can share the screen so we can all have a look. Okay. Can you see the
Yep.
my screen? Is it of a big enough that you can see? Okay, let me get rid of that for now. Okay, so this is when you're actually asked to fill in the asked to fill in the form. This is essentially what we're trying to say. Do they fit the private standards, or in commercial drivers, they need to fulfill the commercial standards for licensing? So this actually says, and I think that the two is not that different here, actually. So if you think the patient has established sleep apnea syndrome, and sleep apnea syndrome by definition is a sleep apnea on a diagnostic study and moderate to severe excessive daytime sleepiness, or if you think the person has a frequent self-reported episodes of sleepiness while driving, or if they have had crashes caused by inattention or sleepiness, or if you think the patient represents a significant driving risk as a result of a sleep disorder, then they do not fulfill the standards to hold an unconditional license. And that's actually no different whether it's for commercial or for private drivers. And then this then went on to say that, look, you can possibly get a conditional license if you actually comply with the treatment and the response to treatment are satisfactory. And so, and this is again the same whether you're a commercial driver or whether you are a private driver, and this is the standards. So this is how I would usually frame my conversation. And at the end of the day, I tell my patients, and I have plenty of patients who are commercial drivers, I'm not here to stand in between you and your livelihood. My interest is to make sure that you're safe, you fulfill the standards so that you can continue to do the job you do. And let's work together to get it done. So it's not me against them. It's let's try to achieve what RTA says we need to do so you can continue to drive. Does that help?
Yes, thank you so much, Dr. Huang, for sharing that. We're right on 8:30 now, so if you have any last minute burning questions, please pop them in the Q&A now. But while you're doing so, I'd just like to say a big thank you again for everybody attending tonight, and especially to Deb and Carol for such excellent presentations this evening. Just a reminder that all of our upcoming webinars can be found on our CHN webpage under the events calendar. And that your evaluation survey for tonight's webinar will be sent out shortly. So please fill in the post-event survey so that CHN can email you your certificate of attendance for this evening, and so that you can self-report your 1.5 hours of educational activities to your CPD home. Resources, presentation slides, and YouTube recordings will all be emailed out to participants who complete their post-event evaluation. We've got just one more question in the Q&A, if you don't mind. Oh, it's gone. Where did we go?
Yeah, try to answer it.
That's okay.
Yeah, so the question is, since most obstructive sleep apnea are related to obesity, or at least a big contributing factor to the development of OSA, should we not intensively and aggressively work on this factor, which is obesity, especially in young individuals which is becoming even more common lately, in order to prevent such young patients dependent on CPAP therapy lifelong?
Absolutely.
And I think that I can't agree with you more. And the other thing we need to remember is poor sleep is a driver for weight gain. So, and if you look in the literature, just by giving patients CPAP to treat their sleep apnea does not result in weight loss. So think we should treat both sleep apnea and we should treat obesity concurrently. And by treating obesity, we can significantly reduce the severity of their sleep apnea, and in some cases, actually push sleep apnea into remission.
Yep. And I mean, you could have a whole talk on the challenges involved in treating obesity, the way our healthcare system is set up. But I absolutely agree with you. And I think if we're diagnosing sleep apnea, we should be diagnosing their obesity too, if that's present.
Perfect. Well, I think that's all for this evening. So thank you again, Carol and Deb, and to everyone else watching at home, good night and thank you for coming.